In the first part, we have seen augmentation of severe atrophy at the area of right maxillary molars. The vertical augmentation was performed via sinus elevation procedure and vertical augmentation with autologous only bone graft. The horizontal augmentation was also done by autologous only bone graft. Now we are 6 months after this procedure. One can see in the panoramic view, the right upper side of the panoramic view, the area of the augmentation procedure. You can see the screws, the 1.5 self-tap titanium screw, both the vertical and horizontal screws, and you can see the bone, both the blocks and the bone in the sinus floor. If we look at the CT scan, one can see clearly the area of the augmentation and the difference between the vertical augmentation done via a sinus elevation procedure and the augmentation, the vertical augmentation with the autologous only bone graft on a bed of a bone substitute saturated in PRP. Also, one can see very clearly the horizontal augmentation via the autologous bone graft, again on a base of a bone substitute, a xenograft material saturated in PRP. And as you remembered in part 1, all were covered with PPP, platelets poor plasma, harvested from the peripheral blood of the patients and treated with human thrombine. If we look at one section at the area of the future implants placement, one can see clearly the different density of the different augmentation material and also the area of the original bone. The original bone looks more radiolucent since it's less dense, of course, in the posterior area. We can also see very clearly the window, the area of the window. So we plan 3 implants in this area. First, we do, of course, local anesthetic, and the cut is done to perform a special soft tissue manipulation, the roll-up technique, illustrated in this illustration, partial thickness at the palatal area, and then separation of the mucosa, and roll up the mucosa toward the buccal area under the buccal flap, and then implants are placed, and then the tissue is sutured with the rolled connective tissue at the buccal side. Now we go back to the video. Screws are taken out. And sample is taken to examine the amount of new bone formation at the area of implantation. Usually I use, after only bone graft, I use either zirconia drills or ceramic drills, as I use here. Implants are placed with no shear forces. If needed, one should do tapping. Implants are buried. A small buccal fat pad was performed, as was done in the previous operation. One can see very clearly the roll-up technique now, pushed under the buccal side and suture with 5/0 nylon suture, with a vertical mattress suture with a loop. Continuous mattress sutures as well. If we look at the slide, this is the situation just after the flap was performed. One can see here the 6 screws, the self-tap screw. So the most interesting part is the amount of bone resorption. So you see that there is hardly bone resorption in this technique, and the screws are laid almost flat with the bone. After they are removed, one can see the holes here, but I would like you to pay attention to the small blood vessels. Those are new blood vessels, can be seen very clearly on the horizontal graft as well as on the vertical graft. And also you can see the connection between the 2 separated blocks that were placed there and the bed of xenograft material that was saturated in PRP, and all were covered with PPP, and those are the 3 implants placed in these onlay bone grafts. 6 months after implants placement, the uncovering, the second procedure, is performed. Before, a panoramic view is taken. Again, one can see very clearly the augmented bone at the area of the atrophy. Please pay attention to the fact that both vertical augmentation via a sinus elevation procedure and augmentation with autologous bone graft was performed to decrease the intermaxillary space and increase the vertical dimension. So mucoperiosteal incision is performed, and narrow diameter healing abutments are placed to prevent any pressure on the overlying soft tissue. One can see here that following the roll-up technique that was done 6 months prior to this procedure, we have quite nice attached gingiva here, and now the patient is referred to the prosthodontist for the rehabilitation.